The major outcome in epilepsy, in the epilepsy field, is making a patient seizure-free. So everything is concentrated on the seizure count. Problem number one is that we don't have a reliable seizure count unless we record the EEG. Newer developments truly can record seizures subgallial for days, weeks, months, and years. But seizures are not the only outcome. They are the core, but they are not the only outcome. Number one, patients with drug-resistant epilepsy have a higher risk to die compared to the normal population. The risk of having SUDEP is 10, 15, or 20-fold increased to have a sudden death as compared to the general population. Overall, a patient with seizures, with epilepsies, having at least a twofold risk to die. So we have to change that. Why do they die? Not only because of the seizures. Some of the causes of death are related to the seizures themselves, such as SUDEP. Some of them are related to the cause, such as metabolic disturbances or genetic disorders, which invariably leads to a premature death. And some of them are related to somatic comorbidities, for example, post-stroke epilepsy or epilepsy with autonomic failure, having an asystole. So what we have to think on is treat the seizures, treat the underlying cause, and prevent the comorbidities. There's a special population which is especially prone to comorbidities and to other outcomes, and they are especially drug resistant, and these are called epileptic encephalopathies. Many of them, or most of them, start very early in life. The Dravet syndrome is, for example, one, but SCN1-8 diseases or CDKL5, they have severe developmental delay. They have severe somatic and psychiatric problems, anxiety, mood disturbances, intellectual disability. And when we talk about this population, we have to take into consideration every factor for improving the quality of life of these patients and the caregivers. Improving urinary incontinence, for example, in these patients is something. The other thing is, of course, improving sleep quality in these patients. So these are little steps if you look at these severely disabled patients or severely impaired patients, but it's a big improvement for the care. So we have to take everything into consideration here and include also patient-related outcomes. For some patients, the seizures might not be the worst thing, but the ataxia is one of the worst things, or myoclonus, or memory problems, or sedation. So these are the other outcomes what we are going to talk. And when a new drug enters the market, additional measures or secondary outcomes are more and more important in these specific patient groups.